degrees of renal failure. And here we can look at enoxaparin, and you can see the area under the curve increases with increase in severity of renal failure. There's certainly an increase in the Cmax. Time to maximum increases slightly, but there's quite a marked prolongation in the half-life. So the half-life telling you that these drugs are acting for longer than you anticipate. So these drugs are important to be adapted for renal failure. Dabigatran is also influenced by renal dysfunction. You can see area under the curve increases very dramatically. Forget about the end-stage renal failure, they used a very different dose there. The Cmax didn't change too much. The Tmax didn't change, you didn't expect that to change, but look at the half-life, it doubles. So your drug exposure is now very much changed in patients with changing renal function. Rivaroxaban is influenced by renal function, 10 milligrams, but to a much lesser degree. You can see the area under the curve, and the half-life is increased by about 20%. So it is influenced, but not to the same degree. Now, if you look at the pharmacokinetics from dabigatran, you can see here, don't look at the dialysis, that's different doses. You can see that in patients with CKD5, how, you're looking into 48 hours still with the drug around. So this may help explain what was happening by the prescription to elderly people who may have had an EGFR that was in the range you're allowed to use it, but maybe was much worse than actually considered. And rivaroxaban, you can see there are changes, but to much less degree with change in renal function. And apixaban also is much less influenced by renal function. So when we look at this and what's recommended by HARDA in Journal of Clinical Pharmacology, unfractionated heparin, no dose change. Enoxaparin must be significant dose reduction. And warfarin, they agree with the sort of data they're looking at, contraindicated. Certainly I have been using warfarin in these phases. Rivaroxaban, 30 to 50, not required. Probably you should be cutting it to 15 milligrams here from 20. 15 to 29, again, in ROCKET they excluded those patients, but there is some data of the use in 15 to 29. But again, less than 15 we really not recommend, probably contraindicated. And dabigatran, you must start dose reduction much earlier, and probably at 15 to 29 you should say this drug is contraindicated. Okay. So just look at the patients. 20% of the patients had EGFR, so 30 to 49. So that's basically the stage 3 CKD, and they received 50 milligrams. The primary efficacy endpoint was slightly higher events rates than normal renal function. These are the data. Same with warfarin. But the safety was a bit better with rivaroxaban, with a significant reduction in fatal bleeding with rivaroxaban. So, and note, patients CKD4 and 5 were not entered in the study. So it comes back to the whole question that we still, despite the new anticoagulants and the excitement of these anticoagulants, we do still have to exercise responsible prescribing, because every anticoagulant, even aspirin, has a hemorrhagic risk. So we need to be careful and take cognizance of all these factors involved. One of the things that Bayer is doing, and I'm sure other companies are doing, is bringing in a patient card, telling them what to do, telling them how to take the drug, how to seek medical help, and so on and so forth when they're taking rivaroxaban. Just to go through the dosing, for venous thrombosis protection, replacement surgery, 10 milligrams, knee surgery, 10 milligrams, and for DVT, for treatment of DVT and recurrent DVTs and atrial fibrillation, here 15 milligrams for 3 weeks, then followed by 20 milligrams. And for atrial fibrillation, 20 milligrams with dose reduction and renal impairment. Just to note, this has not been registered yet in South Africa for treatment, although in the EMA and FDA this has been registered. Now, and there's the hematologist in the audience, and I don't want to spend too much time with this, but when you convert from VK to new treatment, you stop the VK, and when the INR has reached a certain predetermined point, definitely not above 3, but below 3 or 2.5, you introduce the new anticoagulant. When you go newer treatment to VKA, it's course, it's important to have overlapping therapy. You can't just stop the warfarin and wait 2 weeks and then start it, because these patients may be hypercoagulable in that phase. So you stop once the INR is greater than 2, and then INR measurement should be done 24 hours after the last administration of rivaroxaban to the next one. Heparin to low molecular weight and vice versa. Heparin just start at the time of discontinuation. Low molecular weight starts 0 to 2 hours before the time of the next scheduled administration, and rivaroxaban to IV anticoagulants administered the next planned dose. Of course, the big problem here, as I alluded to, is we don't have an INR. And we really need something that is clinically relevant and gives an idea of what's going on. And I suppose in the standard patients with normal renal function, without comorbidity, it's probably very safe. But once you get into the comorbidity situation with chronic kidney disease, you really probably need to have an idea where you are and give you a bit more confidence about what you're doing. But we need to establish these assays, and perhaps I'm not an expert on this and I've just listed them. Patients with renal impairment, again, I've been through. And if hepatic impairment is a no-brainer, if you've got severe liver disease, of course it's not a good idea to use anticoagulants in severe liver disease. And of course, there's always the drug interactions. I mean, warfarin is a minefield of drug interactions. Unfortunately, with rivaroxaban, the drug interactions are low propensity. They're mainly through cytochromes and the PGP pathway. And any very strong inhibitors of these pathways or promoters may influence the pharmacokinetics and pharmacodynamics of the drug. So the ones that are really a problem are the systemic azole antimycotics and HOV protease inhibitors. Of course, if other drugs influence the pharmacodynamic effects, you've obviously got to use with a lot of caution, like aspirin, NSAIDs, and so on. And dual-plated therapy, we haven't really established, but I'll show you some interesting data from the ATLAS study. Because some of these patients have dual indication for aspirin and clopidogrel, and they're in atrial fibrillation. And what should we do in that sort of situation? So the macrolides are always a problem with drug interaction. They're probably not relevant for rivaroxaban. We've discussed that. And these commonly drugs, there doesn't appear to be any clinically significant drug interaction. These ones are a problem, and these are actually very well known to you. And of course, you've got to administer with caution. But it'd be nicer to have some kind of idea of what the level of anticoagulation was when you administer with caution. These are ones that are really a no-no. These very strong inhibitors, like ritonavir. And fluconazole is probably the safest one if you're going to use it. But these ones you really should not be using with rivaroxaban. And again, as I come back to you, the dual indication, there's very little experience, but there's a new study. It wasn't a dual indication study, but it gives some nice information regarding this. And this is just before I show you the ATLAS study, just to show you that if you're looking at CV death, MI, and stroke post-event, that's the level, if you have no aspirin, the level of hemorrhage. You have aspirin, the hemorrhage risk goes up. You add aspirin clopidogrel, the events go down, but hemorrhage go up. You add a stronger prasugrel, it gets better and hemorrhage goes up. Okay? And an even stronger one, the events go down, but hemorrhage goes up. So this is the kind of balance we've got to try and achieve. Now this is the ATLAS study, where they looked at patients with STEMI, end-stage or unstable angina, with these kind of scoring systems, age 18 to 55, with diabetes mellitus or prior MI, and they're given aspirin and their cyanide pyridine like clopidogrel. And they excluded patients, obviously, with history of hemorrhage and low platelet counts, etc. Now, what was very interesting, they used a very low dose of rivaroxaban here, 2.5 and 5 milligrams. And I'm sorry, that has actually changed color. But there was a significant reduction in the primary efficacy points of cardiovascular death, MI, and stroke at both starter strata. Okay, this was significant. But what was really important is that the 2.5 milligrams was giving you the best event rates. And if you look at cardiovascular MI, stroke, significantly reduced, cardiovascular death, significantly reduced, and even all-cause death was significantly reduced by this very low-dose strategy with aspirin and clopidogrel. And if you look at the safety issue of the fatal hemorrhages, you can see this is the 5 milligrams, and this is the 2.5, and this is placebo. You can see intracranial hemorrhage is increased with the 5 milligrams. So the 2.5 gives you the best safety and efficacy in the study. Okay, the other potential patients with hemorrhagic risk is well known to you probably. Severe arterial hypertension, ulcerative gastrointestinal disease, ulcers, vascular retinopathy, recent intracranial hemorrhage, spinal intracerebral abnormalities, recent spinal, brain or ophthalmological surgeries, history of pulmonary bleeding, and of course it's contraindicated in pregnancy. In overdose, there's probably a ceiling effect at 15 million. Again, there's no antidote. Unfortunately, there's no specific antidote, but there are things that you can try. But nobody's really established what exactly should do. Activated charcoal, manage the bleeding, and it's not dialysable, unfortunately. So it's highly protein bound and can't dialyze it off. Bleeding complications should be managed as you would manage any bleeding, by resuscitating the patient, by prevention of hemorrhage, by pressure, mechanical pressure and surgical intervention. But if there's life-threatening bleeding, then you should consider these factors, and I'm not an expert on this, so I won't say too much more on that. But certainly that could be tried to stop the bleeding when you have a patient on these new anticoagulants. So just coming to the end of my talk, just a kind of summary, the warfarin story. They're both efficacious agents for anticoagulation. There's monitoring here. We don't have monitoring here. This is, and this, I think the monitoring is a good thing. The stability is, I think, crucial for the new anticoagulants. They're a much more stable compound, where warfarin is completely variable. There are lots of changes with food, tremendous about PK drug interactions, pharmacokinetic drug interactions. Pharmacodynamic were the same. Of course, we have an antidote to warfarin. CKD 4 and 5, extreme caution, may be well contraindicated. And CKD 4, a lot of caution, probably contraindicated in CKD 5 for the new anticoagulants. The cost obviously is more costly with the newer drugs, which is understandable. So we're coming to the conclusion, and also what you can do is try and assess bleeding risk, which is these HASBED criteria which have been developed. So you score the person, hypertension greater than 160 systolic, abnormal kidney and liver, you can see it comes into this, stroke, bleeding, labile INRs, elderly, drugs and alcohol. So paradoxically, the things that make you bleed are also the things that make you want to anticoagulate. So that creates a bit of a problem. But what is shown is the more HASBED criteria you have, the more chances you've got of bleeding. Okay? So it's a very well validated score. How you should implement it exactly, I'm not sure, and we'd probably have to use some common sense, maybe the discussion from the floor. So there's a traditional Shona tribe proverb, one who refused advice was later seen bleeding. I think with respect, I've adapted, one who refused advice was later seen with a bleeding patient. So in conclusion, the new anticoagulants are exciting development in the field of anticoagulants. The lack of need for monitoring does not mean that hemorrhagic risk is reduced. Responsible prescribing is important in evaluating risk versus benefits, and particularly renal dysfunction is essential for good prescribing of these drugs and drugs in general. Thank you very much for your attention.